actually hit start. So I'm hitting start now.
Hi, welcome to tonight's Vermont chapter of the American Academy of Pediatrics presentation on protecting our young Vermonters with the COVID vaccine. My name is Leah Costello. I'm a pediatrician at Timberlane Pediatrics in South Burlington, Vermont. I'm here to moderate tonight. Our spotlight presenter is going to be Dr. Yukica, who's from Upper Valley Pediatrics in East Thetford and Bradford is where she practices. She's going to present and answer questions. I'll be here to help see questions in the Q&A and help with answering any questions as well. The Q&A feature of our chat is anonymous, so please feel free to put in any questions or concerns, and we will be able to address your particular questions tonight about the safety and efficacy of this vaccine for children 5 to 11. So I'm going to let Dr. Yukica take over, and thank you for joining us.
Hi, everybody. Thanks for being here with us tonight. I'm Dr. Rebecca Yukica. I am a pediatrician, and I practice in Bradford and East Thetford, Vermont. And tonight we're going to talk about COVID vaccines, particularly in the 5 to 11 age group. So while I get started and start talking about the slides, I would like to invite you to please send your messages, comments, concerns, apprehensions about the vaccine so that I can find out what the things you're worried about so I can try to address that as we go. So we're talking about protecting young Vermonters with the COVID vaccine. Some of the things that we do is, does my child need to be vaccinated? What exactly are we protecting them from, and what are the risks? And those are the things that we hope this slideshow will address. So first I want to talk about how the vaccine works, and I'm going to do a little bit drawing here, so bear with me. I'm hoping my lighting is okay. So the COVID vaccine is similar to other vaccines that you've gotten, that your children have gotten. It is a little bit different in that the technology that we're using for the vaccines that children get is an mRNA vaccine. And that alone has caused a lot of apprehension in parents. So I want to break it down as to what exactly that is. And so let me make sure my picture will work here. So you've all seen way too many times this molecule, which is our, I hope you can see it. That's our COVID virus. And among this, the part that's most relevant that I want to draw your attention to are these pieces. These are the spike proteins. And why is the spike protein relevant when we talk about the vaccine? Anytime you develop a vaccine that is going to treat either a virus or a bacteria, you need to have something about the virus or the bacteria that the body's immune system can recognize. When it comes to the COVID vaccine or the COVID virus, it's the spike protein that is being targeted. And so what the vaccine, the mRNA vaccine is it's an injection, of course, of mRNA. And so that's my needle with the mRNA in it. And the mRNA is actually the blueprint, the instructions, the recipe, however you want to think of it, for your body to produce spike proteins. So you're given this vaccine with mRNA, and then once it's in your body starts to produce spike proteins. The spike proteins are then floating around in your bloodstream, and your body recognizes them as foreign. Because it's just the spike protein and not the entire virus, it can't actually make you sick. But your body recognizes it as a foreign protein, and then your body starts to produce antibodies for the spike protein. So now you've got spike protein floating around, antibodies floating around. The antibodies are your body's immune system that is prepping your immune system. So if you ever actually come in contact with the actual virus, your body will be prepared with an antibody army ready to go. The antibody army will tag the virus. Your immune system then kicks up even more destroys the virus, chews it up, spits it out, and you get better. So that's what we're talking about in this vaccine. That's how this particular vaccine works. The mRNA vaccines, although this is the first large-scale virus that we've ever been able to use this technology for, the technology is actually not brand new. The technology has been around and used for cancer in immunotherapy for years. And so if somebody has a cancer that's not operable, the doctors will take a biopsy of the tumor, they'll break it down to what proteins are in it, and then if they can write the mRNA, I believe it's for about 20 proteins. In that case, it's not just a spike protein, it's multiple proteins they're trying to do. They'll reproduce that mRNA, inject it into the cancer patient's body, and then the cancer patient's body will recognize these foreign proteins, develop antibodies against them, and their immune system will then destroy the cancer. So that's one of the uses that this has been in place for years. Now we've just kind of harnessed that technology for this virus. So it's really cool science, and that's the science behind this, how this vaccine works. To back up a little bit and go back to our slides. So the pathogen, the SARS-CoV, the COVID-19 invades those the balls that I showed you, the spike proteins multiply. The vaccine stops this by helping the immune system make the antibodies which fight the vaccine. After vaccinating, your child or yourself has less of a chance of getting an infection from the virus because the immune system fights it off sooner. If they do get infected, they tend to have milder cases and get better sooner. They can still be contagious, but less contagious because the virus has less time to multiply in their body before their immune system takes care of it. All right. How effective are the vaccines? They're actually quite effective. Now, this is also a moving target. The COVID, that little viral particle that you see, is going to mutate. It has mutated. I'm sure you're all sick of hearing about all the different mutations. Delta being the now more remote one, and Omicron being the newer one. So the mutations happen, and so it's hard for us to say exactly how effective it is, but we so far are having really good luck with it. So for the most part, most people who are vaccinated are not getting sick. Those who are vaccinating are vaccinated do have breakthrough cases, but they're much less likely to need to be hospitalized, much less likely to be intubated, and much less likely to die. So for years and years and years, I talk about this with the flu vaccine. People say, oh, I get the flu vaccine, but I still get the flu. And I say, yeah, of course you still get the flu. It's not a perfect vaccine. None of our vaccines are perfect. But the point of the vaccine is that if you do get the illness, you don't die. If you do get infected with COVID after you've been vaccinated, you're much less likely to have a serious illness or to end up in the hospital. You're also less likely to have the long hauler syndrome and the other things that we worry about that are consequences of the virus. We do not know how long the immunity will last. We obviously can't predict the future, and we're trying very hard to figure this out. When the vaccine is new, we can only study it for how long we've had it, but we have really good indications that the vaccine is working well. We have found that boosters are important. I get the question often, is this going to be an every year booster? How many boosters are going to be needed? And my honest answer is, we honestly don't know yet. So right now, it looks like adults really should be getting 3 doses. Pediatrics right now, age 16 and up, have been cleared for boosters. Age 5 to 15 are only recommended to get the 2 doses. And we'll see how things progress. It depends in part on what mutations we see in the future. How do we know that they're safe for children? They have been tested and tested and tested. And so we have found that the COVID vaccines are safe. They're effective for 5 years and up. So far, it looks like the studies in age 6 months through 5 years are also finding the vaccine is safe. We have not yet found the dose that's effective, so we have not released that yet. There have been many randomized placebo-controlled studies in each age group. And at this point, we've got really good data because this vaccine's been given now for over a year in our country alone, and it's been given around the world. And so we've never, I don't think, ever studied a vaccine as much as we've studied this one. We are continuing to monitoring them very closely. Of course, the CDC has ongoing studies. And so it's fair to say that it's the most intensive safety monitoring of a vaccine in history. Time frame, for those of you who are curious, the vaccine was released in December of 2020 for emergency use authorization for the older population. Just to take a moment to talk about why that is. When it comes to medications, vaccines, anything that we do in the medical world, we really need to worry about safety and the pro-con risk-benefit ratio. And so when COVID was new and we were first releasing the vaccines, we knew that the highest risk was till the population 65 and older. So it was more prudent to try to protect those 65 and older because the risk of vaccine was far outweighed by the benefit of, the risk of disease far outweighed by the benefit of the vaccine. Then we continued to collect data, continued to study it, and with time found that the vaccine is indeed safe enough that those who are at less risk for serious illness, it's now considered the benefit outweighs the risk. So in May of this year, the emergency use authorization was extended to include the 12 to 15-year-olds, and it was recommended for use. And then finally in August, we had full FDA approval for the age 16 and up, which means age 16 and up is no longer operating under the emergency use authorization. That's a full-fledged approval. Under age 16, it's still in the EUA category. Something that's maybe not all that important, but a lot of people are kind of curious about is the concern, are vaccines going to be made mandatory for school? And so it's my understanding that vaccines cannot be made mandatory while they're under the emergency use authorization. Once they have full FDA approval, then I believe they're fair game for being required. Not giving my opinion, just saying, I believe that's what the rules are. As of November this year, we finally got the emergency use authorization for 5 to 11-year-olds, which I'm sure many of you know, which is why we're talking tonight, so we can address anybody's apprehension about being vaccinated in that age group. In the United States, over 100 million people have been fully vaccinated. That means at least 2 doses with the Pfizer vaccine. 15.7 million children aged 12 to 17 have been fully vaccinated. And as of the 14th, so a few days ago, over 5.5 million children aged 5 to 11 had received at least 1 dose of the pediatric vaccine. In pediatrics, it's a smaller dose. It's 10 micrograms. In the adults, it's 30 micrograms. If anybody's curious, in an adult, the dose is, I believe it's 0.3 milliliters, where in a child, it's 0.2. It's a very small volume of fluid that we give. For any children who are nervous about shots themselves, or parents who are nervous about shots, this truly is a much smaller needle than we use for most vaccines, and it's a smaller volume, and so it hurts less. And that's definitely the experience I've had with my patients. The pediatric dose of the 10 micrograms, it elicits a similar immune response to that seen in the 16 to 25-year-olds who have the higher dose. It is 90.7% effective against COVID-19 infection. That's data for what it's worth collected during the Delta wave. We'll see what happens with this new variant. There have been no serious adverse events related to this vaccine. There's been a lot of concern about that. In the first week we were able to get our hands on the vaccine, we did 4 COVID clinics in schools, and the kids were adorable and they did really great with it. And they really haven't had as much soreness, fevers, all the side effects that their parents had, the kids have not had, which the parents have been thrilled with. All right, and so this slide is just talking about a study overview. It's an ongoing phase, 1, 2, 3 randomized, observer blinded, placebo-controlled study to look at the immunogenicity, or the strength, the efficacy, which means how it works, and the safety of the vaccine. In phase 1, it was the 5 to 11-year-olds, and they got doses of 10, 20, or 30 micrograms. And then in phase 2 and 3, they did the final dose of that age group, which is the 10 micrograms, and they had really good outcomes with that. I believe this is a 2-to-1. So what the 2-to-1 means is that for every 2 patients who got an actual vaccine, 1 got a saline injection. And so they got dose 1 on day 1, and then 3 weeks later they got dose 2, and then that was 2 out of 3, and then the third in the group got a saline placebo. They then looked at the immunogenicity data for the patients, the efficacy, and the safety, and they compared the 2 groups. What they found is that some kids don't have side effects at all. Those who do have side effects, the most common side effects have been a local reaction, basically pain, redness, or swelling at the site of the injection, and then less so systemic symptoms such as headache, fatigue, and milder than what the teenagers had, which was milder than what the adults saw. The side effects are temporary and go away within a few days, typically within about 12 hours. All right, there are a couple of slides here that are just some data for those of you who are really interested in data. And so this is the local reaction, the local reactions by maximum severity within 7 days after each dose in 5 to 12-year-olds and 16 to 25-year-olds. So you'll see a lot of green bars. The green bars are the mild reactions. The blue shaded areas are moderate, gray is severe, and then the red is grade 4, which is the most severe. And so the top bar across is dose 1, the bar down the bottom is dose 2. And so you can see that redness and swelling were pretty mild. And then pain at injection site was the bigger problem for this age group. Systemic events. So this is a similar graph. What's really interesting, I want to bring your attention to on this graph is that the top bar across is talking about the vaccine. The second bar across, the second bar below is a placebo. And so it's interesting that you had more fatigue and headache in both groups, whether they got the actual vaccine or just the saline. It looks like chills, not so much. People who got chills tend to had really gotten the vaccine than those who did not. And then muscle pain was more common those who got the vaccine than those who did not. But it's an interesting graph. Fever was not really reported in those who did not get the vaccine, in those who got the placebo, only in those who got the vaccine. All right. And then the big thing that is concerning to me and a lot of my patients' families was, what about vaccine-associated myocarditis? So far, there have been no cases of myocarditis in the 3,000 5 to 11-year-olds who received the vaccine in the trial. And we do expect that this is now far enough out that if they were going to get myocarditis from the vaccine, we should have seen it by now. We know that there is an increased risk of myocarditis in the 12 to 17-year-old males after the second dose of Pfizer, but it's extremely rare. Even in the group most affected, which was the 16, I think to 18, I can't see the slide, males, the ratio of myocarditis after the second shot was 1 in 10,000 or 0.01%, which is a pretty small number. Important considerations about this is that COVID itself can cause myocarditis in children. And if you get myocarditis from the virus, chances are you're going to have a worse outcome, a more severe illness, than if you get myocarditis from the vaccine. And so again, weighing the risk-benefit ratio, it seems better to be vaccinated even with this very tiny risk than not be, because your risk is greater from natural disease. No new vaccine side effects have been documented, a few weeks, more than 8 weeks post-vaccination. And there, excuse me one sec. Yeah. There's no biologic mechanism by which the vaccine could cause a new long-term program, since the mRNA degrades within days. And this is really, really an important point. One of the things that a lot of families worry about is that this is an mRNA vaccine, and they worry that we're altering their child's genetics. But this vaccine is not gene therapy. So in conditions such as cystic fibrosis, we're trying really hard in the scientific community to develop gene therapy where we can actually change a patient's DNA so they can produce various proteins long-term. That's not how this vaccine works. The mRNA that we talked about that got injected into the body, does its work by causing the body to produce the spike protein, but then it's gone. So within a few days, the mRNA that you received is out of the system. It does not alter the DNA or the RNA in the person's body. So it can't cause long-term problems in that regard. I believe that because this term, the mRNA, is used, I think that has scared a lot of people, and that's where the thought that it could somehow affect pregnancy or fertility down the line comes from. I've talked to so many families about this, but it's not possible because, again, it's not altering DNA or RNA. So that is definitely a fear that I hear about, but it's one that you can feel reassured it's not a possibility. There we go. So risks of COVID-19 infection, the 5 to 11-year age group. So this is important because this is where you need to temper what is the risk benefit ratio for your own child. So there have been more than 8,300 hospitalizations as of early October of this year. About a third of the hospitalization children in this group require ICU admission. I do believe that it is my understanding, and I hope I'm not misspeaking, that no children in the state of Vermont have needed to be ventilated for COVID. I'm sorry if I'm wrong about that, but that's my understanding. Death by age group from January 1st of 2020 to October of 2021. As you can see, children at the greatest risk are under age 1 year. And of course, we're not yet offering the vaccine to children that age group. However, that is why we emphasize the importance of vaccinating those who can be vaccinated. The best way to protect young children is to vaccinate everybody who they're in contact with, especially household contacts. So when looking at this graph, the age less than 1 year to 4-year-olds are not candidates for vaccine yet. The 5 to 11-year-olds, which are the dark blue, is the age group that we're talking about. There have been 94 COVID-19 deaths in our country, and that's what we're trying to prevent. So that's 1.7% of all deaths among children 5 to 11 years old. Because remember, 5 to 11-year-olds are not supposed to die. They're supposed to be our healthy children with many years ahead of them. And so 1.7% of all deaths in that age group is pretty concerning. It's definitely not nothing. And then as you get older, of course, the risk increases. Okay, so this is Vermont cases from December 12th, as of December 12th, 2021. On the left-hand side, it's the number of cases by week. The orange is total pediatric, and then the gray is total non-pediatric. And so we had a really good summer, a really great summer, and then so many more cases since school started this year. And that's been the trend in all age groups. And then when you look at number of cases by week, by age on the other graph, you see a similar trend, is that we all had a very good summer. Ages 0 to 5 sure make up a hefty chunk of that grid. 6 to 11 is larger than the 0 to 5s, and then 12 to 18s is also significant. And we're hoping to see this is going to drop now that we're, at least in the 6 to 11 group, we're hoping is going to drop now that we can vaccinate them. That's our goal. And this is another way to look at the same kind of data. So Vermont cases, again, by December, up till December 12th this year, rates by week, by age category. And so the age that we're talking about that we're encouraging to be vaccinated are the maroon color at the top. That's where we're seeing most infections. It's not a surprise because they're pretty active. They go to school, they socialize, and they have not yet been able to be vaccinated. In the age 0 to 5, they're still higher than age 12 to 18, which I think is largely because our vaccine has worked in the 12 to 18-year-olds. All right. And then this is just kind of for fun to look at cumulative COVID-19 cases per 100,000 children, and this is stratified by state. So overall, Vermont's done pretty well, not as well as I had hoped. We were at the bottom going into this fall, I believe, but we've had some cases. So this data is calculated using state level population estimates from the Bureau. Overall rate, it's 9,562 children have had COVID-19 per 100,000 children in the population. 11 states reported more than 14,000 cases per 100,000. Thankfully, Vermont's not in that list. And then one more population slide. This is the proportion of eligible U.S. children aged 12 to 17 who received at least one dose of the COVID-19 vaccine by state of residence. And I'm proud to say that Vermont ranked number 2, I believe, only behind Massachusetts. I can't see the full slide, but I'm pretty sure that's my memory is correct. All right. When children do get COVID, they can get pneumonia. That can lead to low levels of oxygen in the blood, which requires hospitalization for oxygen supplementation. It also requires support for machines to assist in breathing. That's what we're desperately trying to avoid. It also, could just cause colds. This is the more severe case. In severe cases, we have found that, again, the vaccine does not prevent cases entirely. It certainly decreases cases. That 90% effectiveness that we talked about is what you can see here when the second bullet says, national data show unvaccinated adolescents are 10 times more likely to be hospitalized due to COVID than vaccinated adolescents. And that's what we're talking about. That data comes from 90%, the vaccine being 90% effective. So it's working. It's not perfect, but it's working. The other question that I often get in my practice is about MISC, the multi-system inflammatory syndrome in children. I can say with confidence that I have not diagnosed this, and I'm pleased that I haven't had to. One of the reasons I will not diagnose this is that part of the diagnosis requires that you're sick enough to require hospitalization. I no longer work as a hospitalist, so I won't be caring for anybody in the hospital with this. But in order to meet criteria for MISC, you have to have laboratory evidence of inflammation, evidence of severe enough illness that requires hospitalization, and at least 2 organ systems need to be involved. Myocarditis is listed here because it's one of the ones that we talk about, but it can also be respiratory. It could be any part of the system can be involved. We've even seen skin rashes and whatnot. It can be in recent or current COVID infection. So far, there have been 5,972 cases in the United States and 52 deaths. I believe there's been 1 case in the state of Vermont that's been confirmed by the CDC. There have been more cases with concern of possible MIS-C syndrome, but not confirmed. All right, and so by age group, it's the 5 to 11-year-olds who are at the greatest risk for this post-infectious inflammatory syndrome. And so we're trying to prevent this by vaccinating this age group. And then we're going to talk a little bit about benefits. For every million Pfizer vaccines in children 5 to 11 years of age, we believe that we are that we've prevented 57,000 cases in females, 57,000 cases in males, over 400 or about 400 hospitalizations, 130 MIS-C cases in each sex, and about 120 ICU admissions total. But this slide breaks it down between males and females. So again, whenever we're talking about a vaccine, a medication, we always want to talk about weighing the risk and the benefits to the individual patient. Is this going to give them more good than cause harm? And so some of the things that the state and the government has looked at is the benefits, which include preventing cases, preventing hospitalizations, ICU stays, and of course, death. And the risks include myocarditis, pericarditis, cases, hospitalizations, ICU stays, and deaths. And so clearly, it seems like this is clearly the benefit outweighs the risk for all of this. Things that aren't considered in that study are all the other benefits that you get from being vaccinated. We mentioned that you can get myocarditis from the virus and that it's more severe if you get it from the virus than if you get it from the vaccine. But there's also all the other side benefits to vaccinating. So you'll have less transmission. We'll have less community burden the more that we vaccinate. There's less disruption to in-person learning due to illness or exposure. The state of Vermont has done a beautiful job giving schools guidelines on how to treat exposures at school. Because I practice in Bradford and East Thetford, I'm on the border of Vermont and New Hampshire. And so I have a really good view of what's going on in each state. And I can say it's much more comfortable in Vermont than in New Hampshire, where New Hampshire's adopted more of it. Each school district will decide what to do on their own. which is really a bit chaotic. In Vermont, when you follow the flow chart that the state has designed, when you have an exposure in a school district, if the child who's exposed is vaccinated, they are able to stay in school and carry on business as usual as long as they're not having any symptoms. If they're not vaccinated, then they have to do the whole quarantine, test out around 7 days, wait for the lab to come back, and then if it's negative, then they can resume activities. So it's a huge disruption to learning and education. And I think we've all found that for the most part, kids do much better in school than trying to learn from home. It's much less burden on families. So that's a side advantage from getting vaccinated. Another thing that's hard to quantify is the post-COVID conditions. So I have seen patients who have the brain fog, the long haulers. Let's see, it's December. One of my teenage patients has had this now. Her COVID was a year ago. So we're on the 1-year anniversary, and she still suffers from serious brain fog. And so I really want to prevent that in as many patients as I can. Unfortunately, she got COVID before the vaccine was available. This is just here because we want to kind of remind everybody that when the voting by the FDA was made to decide to allow the vaccines or not, here's what they were considering. Based on the totality of scientific evidence available, do the benefits of the Pfizer COVID vaccine, when administered as a 2-dose series, 10 micrograms, 3 weeks apart, outweigh its risks for use in children 5 to 11 years of age? And they found overwhelmingly that the answer was yes. So this question was specifically, is it in the best interest of the 5 to 11-year-olds to be vaccinated? And they found yes. This is going to address now some of the common questions that we have again. Why is the vaccine dose based on age and not weight? I love this question. My brother called me up right before the vaccine was released and said, hey, my nephew is huge. He's adult size. Should my brother wait till his birthday to vaccinate him with the larger dose rather than the smaller dose? And my answer was no, vaccinate him as soon as it's available with the dose that's recommended. The reason for this is that vaccines are not medications. What they do is they present information to the immune system that stimulates the immune system to respond. Younger children have stronger immune systems, more of a response than older people, which is why younger people do well with a smaller dose than bigger people. And so it's not age, it's not size, it's really maturity of the immune system. In this case, young immune systems are best. They have more vigorous response. So we base it on their system maturity rather than weight. Any parents who have questions, one of the things that I always point out with the human papillomavirus, some parents like to wait to give the human papillomavirus when their children are older, maybe more likely to be sexually active or closer to becoming active. So their parents are holding off till 16, 17, even later. The problem with doing that is that the immune system in the 12-year-olds is so much stronger that if we give a 12-year-old the HPV vaccine, they only need 2 doses and they're set. If you wait till they're 16, they're going to need 3 doses because they don't mount as good of a response. And so even though they're further, we all hope, from needing the protection from the HPV vaccine, they get better protection later on in life. So hepatitis B is another one. This is part of why it's one of the reasons we give hepatitis B at birth, not because we think that 2-year-olds are going to get piercings or tattoos and put themselves at risk, but because the younger you are when you get the vaccine, the stronger your immune system, and that lasts lifetime. Some not great news on this. Vermonters under age 5 years, clinical trials are underway. They are testing smaller doses, and the hope had been to roll these out in the first quarter of 2022, but the vaccine is not showing to be vigorous enough in, I believe, the 4 to 5-year-olds. Interestingly, I think in the 6-month-olds, they found the results that they wanted, but not in the older young children. So this is not being released yet, and we will wait and vaccinate them when we find that we have the doses figured out. We're not there yet. This is another great question about what about getting other vaccines at the same time? So when the COVID vaccine was first released. The recommendation to adults, for those of you who were getting vaccinated back then, was not to get any other vaccines. I believe it was in 4 weeks of the COVID vaccine. And that was just out of precaution because honestly, we didn't know. We now have plenty of data that we find it's safe and it's effective. You can give multiple vaccines at the same time. You can give them back to back on days. You don't need to worry about how you space them apart. The only exception being live viruses such as MMR, chickenpox, and the nasal flu, the flu spray. Those we like to give separated by either the same day as other vaccines or 30 days apart. So the one, that's the only exception to giving them all and not worrying about timing is live vaccines should not be given too close, either the same day or a month apart. Additional information, it takes about 2 weeks after the second dose to be considered immune. So I have a 6-year-old myself. He's dying to go to the theater to see his brother act in a play that he's performing in. And so we put off tickets until 2 weeks after his second dose. And so come Christmas Eve, he'll be fully vaccinated and he'll get to see his brother in the play. So we're all very excited. COVID vaccines are free, whether or not you have health insurance. And so please don't let that be a barrier to getting your child or yourself vaccinated. They're free to everybody in the country, no matter what. How to register and get vaccines. So I love that this information is in the slideshow because this is not how it works at my practice, but there are lots of vaccines clinics. School clinics began November 8th. Pharmacies have them, although if you have access to a pediatrician or a family practitioner, somebody you have a relationship who does it, I would prefer you do it with them than the pharmacy. But if a pharmacy is easiest for you, go for it. There are plenty, you can easily go onto the Vermont website and find clinics that are available. Also check with your primary care provider. In my own practice, we will vaccinate anybody. We only carry Pfizer because we're a pediatric office, so it makes sense that we only have Pfizer, but we will vaccinate children, we'll vaccinate parents. Whether you're our patient or not, we'll give you the shot and you don't have to deal with the online signing up because I know that's a burden for some people. So if you're willing to do it online, go for it. If that is a barrier for you, give your primary care doctor a call and see what else they can recommend, because we'll help you figure it out. It was hard to get our hands on when it was first new, but I think that we're now a few weeks into, or about 4 weeks into having access to the pediatric dose. So they're getting easier to get a hold of. Here's more information on how to find your vaccine sites. healthvermont.gov/myvaccine. If you Google Vermont COVID, there's a website that'll take you to, and that will easily walk you through the steps of registering. Or you can call the 855-722-7871 number and press 1 if you need a language other than English. And you'll be able to register that way. Here are some more resources for families. I really like the CDC website and how it explains how vaccines work. I think that's a very useful site. And so let's go. Vaccines in little arms as quick as we can. And I think now we can open up for questions if anybody has any.
Thank you, Dr. Yukica. That was fantastic. I loved your drawing at the beginning, explaining how mRNA vaccines work. I've been on a few of these moderating, and that was a first, and it was great.
I draw that all day long. If you come to my practice and pick up tissue boxes, you'll see like on the bottom of tissue boxes, because that's all I had when the patients were in the room. It's everywhere.
I definitely envisioned you drawing it on the paper on the table, because that's where
do that
I
all
draw
the time.
things as well during my discussions with patients. So I love that. And I really just enjoyed hearing your passion about how important and safe and efficacious this vaccine is for our kids 5 and up, and for adults as well, for all ages.
Adults and teens, everybody.
Yeah. And that your practice is really making that accessible to your patients and their families. That's phenomenal. I really common questions that we're seeing here, you really hit upon about why is this dose different for the 5 to 11-year-olds related to their immune system? And I appreciate you covering that, because that's a really common question for families. But on the flip side is a small premature history of prematurity 5-year-old. Is this 10 microgram dose safe for my child who fits that situation? What would you say to that,
Yes.
to that participant?
Yeah, so absolutely. I think that's a really good question. I think it's really scary when you have a child who's had special needs or has been small and they feel like they're a little bit more vulnerable. But again, when we think about prematurity and infants who are premature, usually we consider them caught up by age 1 year. Even if they're smaller, even if they're developmentally delayed, their immune system is ready to go. And so it's certainly healthy and in their best interest to be vaccinated. And the dose for a typical 5-year-old is appropriate for a small premature 5-year-old as well.
Thank you for that really clear answer. Another common question that we have been seeing is, what if your child had COVID? When would be the appropriate time to get vaccinated, and should they get vaccinated if they've already had an infection?
So this particular question is dear to my heart because I have a very good friend and we discuss this often. So yes, you should still be vaccinated. We believe that you have at least 90 days of good immunity. And so it might be most prudent to wait till 90 days after they tested positive to vaccinate them. There are more studies coming out, and I think there may be some decent evidence that after infection with COVID, you may have more like 6 to 8 months worth of immunity. We just haven't quite proven that yet, but we do believe that might be the case. I would still encourage vaccination around the 90-day mark, the 3-month period, because we feel very confident that that's far enough out. There's no harm to being vaccinated, even if one of the things that I get all the time is that if we have a patient who is under quarantine and we're waiting for the results, so we actually don't know if they're positive or not, we still go ahead and vaccinate them if that's their desire, because it will still give them protection. And that's really our goal here, is to give you protection. So there's absolutely no harm in getting vaccinated while you still have protection from wild illness. We don't want too much of a gap between having a wild illness and being over that and then getting vaccinated. So for that reason, I feel like 90 days is a safe mark. One thing that gets complicated that I honestly don't have a great answer for is that I know in Vermont, if you've had a positive test and you have exposure at school, you can still go to school if it's within 90 days of your positive test, because we're confident that you're still protected. But what if you want to get on an airplane or go to a theater or go to a show somewhere that they require vaccination? I don't know the answer to that. Of course, these are less important reasons to get vaccinated than your overall health and well-being. But if going to some social event is really important to you and you need to prove vaccination status, it is safe to get the vaccine sooner rather than later. I just wouldn't wait beyond the 90 days yet. We'll see what the data shows in the future.
And I've been counseling my patients that they can get it as soon as they come out of isolation.
Yeah.
And I've even, I have had, unfortunately, a couple of people who've made it so close to the finish line and gotten COVID right before getting the vaccine, or actually between doses as well, and have counseled those patients to just proceed with getting the vaccine as soon as possible.
I've done car side vaccines while they're in isolation.
Oh, that is lovely that you're
So
offering
if they've
that as
been
well. Yeah.
exposed, if they've been exposed, but they're not symptomatic and they want it, we'll do it.
And I love your point of, yes, we want you to vaccines, to protect your health, but I actually think for kids, like being able to go back to some of these social things, such as going to your son's play, those things are really important. And that's part of your pros and cons list in looking at that it that gets, this vaccine enables kids to get back to school more consistently, back to their social lives, which is a huge part of their development and growth and overall health as well.
Absolutely.
So,
and because it has such a good safety protocol, profile, it's okay to look at it that way. If there was great risk from the vaccine, then we might be more hesitant to recommend that. But it really is truly safe. And so we can recommend it to keep them social.
And I love talking with patients about, yes, it is truly safe. And we have now given, as you pointed out, so many vaccines to kids this age without seeing any triggers or indications of adverse events. It's been phenomenal. So, but I wanted to know if you could just, and actually in that kind of vein, talking a little more about myocarditis, and is it safe for our patients who have, for instance, a heart murmur? Would you consider giving this vaccine to somebody with a congenital heart disease because of that risk of myocarditis associated with the vaccine for teenage males specifically?
So I won't lie, initially I was more nervous about them and more apprehensive. So I did some research and some digging and have actually found that they're the number ones I want to recommend it for. Because if you have a greater risk for any reason, then you really want to be protected. And so I think it's more important for them rather than more dangerous for them. So I highly recommend it in my handful of patients who have cardiac disease, as have their cardiologists.
Yes, as the cardiologists also agree with that statement as well. Talk to us just a little bit about whether you have any techniques for kids who are nervous about the shot, and what you recommend to parents about Tylenol related to the vaccine. You recommend it before or after?
Yeah. So kids are apprehensive. Kids are always apprehensive. If you have the opportunity to do a school clinic, kids actually do amazing in school clinics. Their peers are around them. It's just the normal thing to do. And so kids do really well in school clinics, better than they do with their parents, believe it or not. And then if you have a special needs child, just talk to your physician ahead of time before they give it. We have some really great toys, some distractions that we can use in the office. We've had really good success with that. And we give vaccines all the time. It's what we do. It is, if you have a child who's really apprehensive, those are not the kids I would bring to a pharmacy. Those are definitely the kids I'd bring to your primary care provider. I'd give the provider a heads up if you're nervous about it. I would remind you to not be too worried about it yourself. It's not that big of a deal. Kids do great. And if you need your shot, sometimes kids do great when you get your shots together. So if you have an office that's willing to do that, we do that all the time. It really is kind of fun. And I love it when the kids are brave, but parents are scared. And we see that all the time. So kids do well. It's just really about distracting. One little hint is that if you have a child that's really nervous, dress them in a t-shirt or a tank top so that they have easy access to their arm, because the longer they think about it, the more worried they get. And so you want to be able to whip off their jacket, have their arm be available, get the shot in and out, be done before they even notice, and they'll do great. Also, be matter of fact of it, the more nervous the parents get, the more nervous the kids get. And then the second question was
regarding Tylenol.
Tylenol,
pain medications.
Yeah. So back in the day, it became normal when babies came in for shots. It became normal to give babies Tylenol before they got their shots, so they didn't have a big reaction to it. They could feel well. That has fallen out of favor because we find that when we pre-treat with Tylenol or Motrin, the body's immune system actually has less of a vigorous response. And so we want to not give those medications unless there's a need. So we prefer for you to give them the shot, see how they do. And if they're having enough arm pain or fevers or chills or just really not feeling well, then that's when we want you to give them the Tylenol. So it's a wait and see, use it as needed is best.
I agree with that. In our kind of closing tonight, well, if there's any points that you were hoping to make, but I was just wondering just how you kind of weighed the risks and benefits for your own patients and maybe even your own children in making the decision to vaccinate.
So for my 15-year-olds, it felt like a no-brainer. I could not wait to get them vaccinated. I was definitely more worried about them getting sick than getting vaccinated. And I guess by the time it was available for my 6-year-old, I also had no apprehensions whatsoever. I feel like the evidence is pretty clear. I do understand though that we all have different lives. We have different priorities. We have different social lives, different values. And so I don't think it's a one size fits all. I think it's really important to talk with a trusted physician about the things that you are comfortable, the things that you're worried about, and make that decision. I have patients who have international families and travel, and they were really anxious to get their kids vaccinated even before it was approved. And I understood that. And then I have other families who are pretty content in their units. They don't need to go out much. They don't need to even shop much. And so they are less anxious to get it. And I understand that. And so I think it really does vary on your lifestyle and your values. And so I think it's important to have a trusted primary care doctor you can talk to about this and have a candid discussion about what are your concerns. Sometimes I think it's really important to let your doctor or your nurse practitioner, whoever your provider is, let them know what it is that you're worried about, because there are things that families worry about that we have no idea and would never know to address unless you ask them. And so let them know what it is that you're worried about so they can address that directly with you.
It is so important to have that trusted relationship with somebody. I agree. And we really want to keep talking about that and hear your concerns and talk through it and answer questions. So that's what we're all here to do. Well, thank you for your time tonight. Thank you for watching tonight. Thank you to Elizabeth Fox for translating for us tonight, and Jordan for doing our live captioning. And then we did have Stephanie Winters, the executive director of the Vermont chapter of the American Academy of Pediatrics, in background helping with any tech support, although we did great tonight. And then Dr. Yukica, I really appreciate your time. Your patients are lucky to have you. So
Thank you so much.
yeah, take care.
Safe. Happy holidays.
Thanks, you too.